Hello, Andrea. My presentation is on prevention of central line associated bloodstream infections. This is one of the National Patient Safety Goals, and I use one of the ones for long-term care facilities. The National Patient Safety Goals are mandates that facilities have to use to improve patient care. The performance standards for this National Patient Safety Goal are that the staff would be educated on care of central lines, that there would be a protocol in place for cleansing the hub and the port of the catheter, and that there would be discussions about the necessity of the catheter amongst the intercollaborative team. Problem and impact. According to the CDC, or according to the Joint Commission in 2012, an estimated 250,000 patients in the United States experienced eclampsia. These add up to a lengthened hospital stay and have a per incident cost of about $16,500. It's difficult for them to determine what the death rate is from eclampsia because it's difficult to tell if a patient died from eclampsia or died with one. So they use a formula that extrapolates from the number of hospital-acquired infections each year, the percentage of those that are eclampsias, and then the number of hospital-associated infection deaths each year, and then the amount that they think would be attributed to eclampsia, and that's an estimated 30,000 deaths per year. Research has shown that an evidence-based group of interventions could decrease the incidence of eclampsia by 65 to 70%. I've looked at several eclampsia protocols. They all contain just about the same ingredients. Most of them do address insertion of the central venous catheter. For our purposes, we don't do that here. Our patients come with central lines. Sometimes there are PICC lines inserted on the ward, but we're not involved in that. A staff from another facility comes to do that. The main thing that we need to pay attention to as far as insertion goes is the worst site as far as infection is the femoral site, and then the next worst site is the interjugular. So with those two areas, we need to be extremely diligent in assessing the catheter and taking care of it because those two areas are most likely to get an infection. Eclampsia bundle. The most important part of a eclampsia bundle, the basis of a eclampsia bundle always has to be staff education. Staff should be educated when they're hired, and then they need to be recertified once a year to make sure that they know how to take care of these central venous catheters. Hand washing. Everybody needs to practice good hand washing. Either wash with soap and water, or you need to use one of the hand sanitizers and wash before and after you do anything with the central line. Assessment is imperative. The site needs to be looked at least once a shift. Look at it for redness, look at it for swelling, for drainage, see if it's tender. Any of those could mean that it's getting an infection. Dressings. You can use a gauze dressing. It's preferable to use a transparent dressing, but if the patient's diaphoretic or you just can't keep the transparent dressing on, you can put an occlusive bandage on. Those need to be changed every 24 hours so that the site can be looked at. If you have a transparent dressing, those can be changed every 7 days unless they get loosened or they get soiled, and then you need to change them more frequently. When you do your dressing changes, it's preferable to use a kit with all the ingredients in it. A chlorhexidine scrub is preferable. A chlorhexidine impregnated dressing is also preferable. When you access the central line, the infusion ports and the hubs should be scrubbed for at least 15 seconds with alcohol to make sure that they're cleansed. You can use the little commercial Curos caps to put over the infusion port once you're done using it. Those take about a minute to disinfect the port, and they can stay on there until you access it the next time. And then last but not least, what every nurse doesn't want to hear is this patient comes to you with this beautiful central line, and you need to be sure that the patient needs it, or you should pull it out. But unless these patients are getting blood, getting TPN, getting some kind of vesicant through this IV, it really should be taken out, because as you've seen, there's a high monetary cost and also a high human cost to leaving these things in and getting an infection. The CVC CLABSI definition is a primary bloodstream infection in the presence of a central venous catheter. A central venous catheter is any catheter that terminates in one of the great vessels, superior vena cava, inferior vena cava, aorta. It doesn't matter what kind of catheter it is, it doesn't matter where the insertion site is, it all depends on that terminating point. Primary bloodstream infection is an infection that just comes from the bloodstream. It can't be secondary to an infection in another site in the body, say urinary tract infection. If there's E. coli in the urine and you culture E. coli out of the bloodstream, then clearly that the bloodstream is a secondary site. The E. coli comes from the urinary tract infection. You can draw out blood cultures that will be contaminated by drawing them. Sometimes it'll be just common commensals, bacteria that lives on the skin, other contaminants. If you have two blood cultures from two different sites that you culture that same common commensal out of, to be considered a bloodstream infection, you have to have other symptoms like fever and chills. They can't be just the common commensal, and it has to be two bottles from two different sites. There's also mucosal barrier injury, like necrotizing enterocolitis. I'm not going to go into that one. And then the unit attribution rule. Nobody wants to be caught with this hot potato of being blamed with the CLABSI. So the unit that the patient is on with the central line for 48 hours previously, or 24 hours after, is the unit that CLABSI is attributed to. Okay, patient scenario. We have a 20-year-old patient who comes to us with alcohol-induced pancreatitis. Abdominal CT shows severe pancreatitis with inflammatory changes. Patient's on a ventilator, patient has a tracheostomy, catheters in the right IJ and the right subclavian. On 9/3, an ultrasound for pancreatic fluid. The fluid reveals nothing, no growth in the cultures. On 9/11, repeat abdominal CT. Pancreatitis hasn't changed, but the patient's beginning to get some fluid in his abdomen. On 9/11, 9/14, the patient's taken for debridement, another pancreatic fluid culture. Later that evening, the patient has a temperature spike to 102. The right IJ line is discontinued. The catheter and tip specimens are sent for culture. And on 9/16, the culture results come back. Still no growth in the pancreatic fluid. Catheter tip has less than 15 of an Enterococcus species, and the blood cultures ×2 are positive for Enterococcus faecalis. So, does this patient have a hospital-acquired infection? Answer A, no, these organisms are contaminants. Answer B, yes, there's an intra-abdominal infection with secondary bloodstream infection from an Enterococcus species. C, yes, a central line associated BSI because the blood and the catheter tip grew the same organism. Or D, yes, it's a CLABSI because the blood cultures are positive for a pathogen. There's no evidence of infection at another site, and the patient had a central venous catheter in place. And the answer is D. The blood cultures are positive. There's no evidence, so blood cultures positive in the presence of a central venous catheter, and there's no primary site. And then my review of literature, my first article, Going Beyond Zero Catheter-Associated Bloodstream Infections. An ICU was faced with 4.8% CLABSI rate per 1,000 central line day, and they decided that they wanted to do something about it. They wanted to do something that could be implemented in the ICU and then be transferred to the rest of the hospital where the hospital could use it as well. So evidence-based practices from the CDC were implemented. Education was given to the staff. In 2013, this ICU had an incidence of 0 catheter infections from 4.8%. So this just validates the CDC position. Implementation of that CLABSI bundle decreases CLABSIs. Use of central line catheter maintenance and bundle in long-term acute care hospitals. This was a study that was done with 39 LTAC facilities. Their charts were audited. 14 months passed, and then the interventions were put into place, and then the patients were monitored. The patients that the hospital admitted from that point forward were monitored for CLABSIs. They implemented evidence-based practice. They educated their staff. They immediately began to see a fall in the CLABSI rate, and they saw a 29% reduction that was sustained for the 14 months until the study ended. Just another proof that the CLABSI bundle does prevent and does decrease the number of CLABSIs. Prevention of central line associated bloodstream infections through quality improvement interventions. Systemic meta-analysis. This was a midline search that was done, 42 studies, 584 ICUs, and all of the studies showed sustained decrease in CLABSIs after the implementation of education in a CLABSI bundle. In this last article, I just thought was interesting because one of the hospitals in town is doing this, and I spoke with the infection control nurse there about it. This hospital had already put into place a CLABSI bundle, but they wanted to decrease their CLABSI incidence even more. So they began bathing their patients with chlorhexidine wipes from their jawline to their feet. They used a different wipe for every area of the body. No peri-care was done with it because it's irritating to the mucosa. Patients were not cleaned up when they were incontinent using these products. They were only cleaned, just routine cleaning. This facility was able to maintain long stretches after that without any incidents of CLABSI. And that's the end of my presentation. Thank you for watching.